Welcome, curious minds, to another deep dive.
Great to be here.
Today, we're tackling something really specific, but honestly quite crucial in the world of horse health.
Mm-hmm.
We're talking about the tracheal wash, or TA. It sounds technical, but it's basically a key tool vets use.
That's right. Our mission today, if you will, is to really unpack what a tracheal wash involves, how it's done, why it's done.
And what the results actually mean for the horse.
Exactly. We're going to break it down so, even if you've never really thought about horse lungs before, you'll get a good handle on it.
Okay, let's get into it then.
Right.
So fundamentally, it's a technique for checking out the lower respiratory tract, right? Getting fluid right from the trachea.
Precisely. Think of it like getting a very specific fluid sample, almost like a biopsy, but for liquids. It gives vets a direct look at what's happening down there.
Especially useful for things like pneumonia, or maybe a horse with a cough that just won't quit.
Absolutely. Chronic coughs, infections, that kind of thing.
So I understand there are, well, two main ways vets go about this.
Yes, two primary methods. One's a bit more, shall we say, direct.
Hands-on.
Yeah, hands-on percutaneous. And the other uses some neat camera technology.
Okay, let's start with the first one, the transtracheal wash.
The transtracheal wash, or TTW, sometimes called percutaneous. And yes, for certain things, especially bacterial culture, it's often seen as the gold standard.
Gold standard. Okay, that sounds important. So walk us through that. How does the TTW actually happen?
Okay. So first, the horse is usually sedated, just to keep them calm and still.
Makes sense.
Then a small patch on the underside of the neck, right over the windpipe, the trachea. It's clipped bare and prepped like for surgery. Very sterile.
Right.
Local anesthetic is injected, numbing the skin and the tissues underneath.
Huh.
Then a small stab incision is made.
Okay.
And a special needle, or a trocar and cannula assembly, is carefully inserted between the cartilage rings of the trachea right into the airway itself.
Wow. Okay, so you're actually in the trachea.
Yeah.
Then what? How do you get the sample?
So once that access is established, a thin, sterile catheter is passed through the cannula, or needle, and it's threaded down the trachea towards the chest inlet, the thoracic inlet, where mucus and stuff tend to collect. Then maybe 30, sometimes up to 60 milliliters of sterile saline, just salt water basically, is flushed in quickly.
Flushed in.
Yep, pushed in and then immediately sucked back out, aspirated into the syringe. That saline washes over the lining and picks up cells, mucus, bacteria, whatever's down there.
Got it. So it's a wash.
Exactly. Then the catheter and cannula are removed, little pressure, maybe a small bandage. Done.
So the big advantage you mentioned, avoiding contamination.
That's the key takeaway for the TTW, because you go directly through the skin into the trachea, you pretty much bypass the mouth and nose.
Which are full of bacteria normally.
Right. So you get a much cleaner sample, which is ideal if you suspect a bacterial infection and need a reliable culture.
Makes sense. Any downsides? You said it's invasive.
Well, it is more invasive than the other method. There's a small risk of subcutaneous emphysema, basically air getting trapped under the skin at the site. Doesn't usually cause major problems, but it can happen.
Okay, so that's the TTW. What about the other method? The one with the camera?
Right, that's the endoscopic tracheal wash, or ETW. This is less invasive.
How does that work?
Here, a flexible endoscope that's a long, thin tube with a camera and light on the end is passed up the horse's nostril, down through the throat, past the larynx.
So you can see where you're going.
Exactly, guided right into the trachea. Then a sterile catheter is fed through a channel inside the endoscope itself.
Ah, clever.
And you do the same thing. Infuse saline through the catheter, then aspirate it back.
That definitely sounds easier on the horse. Less pokey.
Generally, yes. And a huge plus is you get to see the inside of the airways directly.
What kind of things might you see?
Oh, you can see if there's lots of mucus, how inflamed the lining looks, sometimes even structural issues or growths, though that's less common.
So visual inspection plus the sample. What's the catch? Is there a downside?
The main disadvantage is that risk of contamination we talked about. As the scope passes through the nose and pharynx.
It picks up bacteria along the way.
Potentially, yes. Which can make interpreting a bacterial culture trickier. Is that bacteria from the sample contamination, or is it causing the problem down below?
Yeah, I see the dilemma.
Vets try to minimize this, of course. They might use special guarded catheters or double lumen ones, or try to get the scope tip really close to the fluid pool before washing. But the risk is still higher than with a TTW.
So the choice between TTW and ETW really hinges on what the vet suspects most strongly. Like, bacteria points towards TTW.
Often, yes. If bacterial pneumonia is high on the list, the cleaner sample from a TTW might be preferred for that definitive culture. If you want to visualize the airways or maybe suspect something like asthma, the ETW might be the better choice. It's a clinical judgment call. Which kind of leads us nicely into the why, doesn't it? Why go through either of these procedures? What are we actually trying to find out?
Right. We know how it's done, but what are the specific conditions or, symptoms that make a vet think, okay, time for a tracheal wash?
Well, it's indicated for a whole range of lower respiratory issues, especially, as we've said, if infection is suspected. It's a really powerful tool.
So, like diagnosing bacterial pneumonia.
Definitely. Identifying the bacteria, seeing the inflammatory cells, and crucially, getting that culture so you know which antibiotic will actually work. No guesswork.
What else? You mentioned chronic cough.
Yes, chronic cough, especially if there's pus-like discharge from the nose, purulent discharge.
Right.
Also, evaluating poor performance in athletic horses, racehorses, eventers. Sometimes a low-grade respiratory issue is dragging them down, even without obvious signs like coughing fits.
Interesting. So it could be subtle.
Very subtle sometimes. Also things like inflammatory airway disease, IAD, or what we now often call equine asthma. Now, another test, a BL, bronchoalveolar lavage. That samples even deeper in the lungs and is often better for really characterizing asthma. But a tracheal wash can still show you inflammatory patterns that point towards it.
Okay.
We can also sometimes detect fungal infections. And a big one, especially for racehorses, is diagnosing exercise-induced pulmonary hemorrhage, EIPH bleeders.
Right, you mentioned that. How does the wash pick that up if the bleeding isn't obvious?
Because even after the active bleeding stops, special cells called macrophages clean up the leftover blood. They gobble up red blood cells and store the iron pigment hemosiderin, so finding these hemosiderin-laden macrophages in the wash.
That's like finding old evidence of bleeding.
Exactly. It tells you the horse has blood in the lungs even if you didn't see blood at the nostrils. It's a key diagnostic finding for EIPH.
Wow. So the signs a horse owner might see: coughing, maybe breathing difficulty, not wanting to work as hard, nasal discharge, fever. Those could all trigger a vet to suggest a wash.
Absolutely. Those are the classic signs. Difficulty breathing we call the dyspnea. Exercise intolerance. Any of those warrant investigation.
And I guess the horse's history matters too, like exposure to certain things.
For sure. If it's a foal, is there a history of Rhodococcus equipneumonia on the farm? That's a specific nasty bacteria. Or has the horse traveled long distances recently? Stress from transport can predispose them to respiratory infections. Or exposure to donkeys can be a risk factor for lungworm. It's all part of the puzzle.
Connecting the signs, the history, and then using the wash to get a definitive look inside.
Precisely.
Okay, so the vet's done the procedure, they've got the fluid, now comes the lab work, right? The real detective stuff.
Yeah.
What are they looking for under the microscope? How do you tell normal from abnormal?
It really is fascinating how much a few drops of fluid can tell you. First, just looking at the fluid itself. Normal fluid is usually pretty clear, maybe slightly hazy, might have some strands of mucus.
Okay, nothing dramatic. What about the cells? That sounds like where the action is.
That's where the story unfolds, absolutely. In a normal, healthy airway wash, the most common cells you'll see are macrophages. Remember those cleanup cells?
Yep, the hemosiderin ones for bleeders.
The very same. Normally, they make up, say, 30 to 70% of the cells. They're the main residents.
Okay.
You'll also see some ciliated columnar epithelial cells. These are the cells that line the trachea, the ones with tiny hairs, cilia, that sweep mucus up and out.
Makes sense. You'd see some of those.
Yep. And some goblet cells, the ones that actually produce the mucus. Then you'll have a few lymphocytes, usually less than 10%. And importantly, very few neutrophils.
Neutrophils, those sound important.
They are key. Normally, you want to see less than, say, 10 or 20% neutrophils. Some labs use 20% as the cutoff. More than that, that's a flag.
A red flag for inflammation.
Exactly. Neutrophils are the immune system's first responders to infection and inflammation. High numbers mean something active is going on. Oh, and you typically see almost no eosinophils or mast cells in a normal sample.
So greater than 20% neutrophils is the big alarm bell. What else signals a problem?
Well, that increase in neutrophils, we call it neutrophilia, is the most common abnormal finding, yeah. And it very often points towards a bacterial infection.
Okay.
But we look closer at those neutrophils. Are they healthy looking or do they look degenerate?
Degenerate, what does that mean?
It means they look damaged, basically. Swollen, maybe their nucleus is breaking apart. It often happens when they're fighting bacteria aggressively. And critically, do we see bacteria inside these degenerate neutrophils.
So not just bacteria floating around, but actually inside the immune cells.
Precisely. Seeing intracellular bacteria, especially within degenerate neutrophils, is really strong evidence of an active bacterial infection. It's a crucial distinction.
Which brings us back to that contamination issue, especially with the endoscopic wash. How does looking at the cells help sort that out? If you just see bacteria, but not many neutrophils, or the neutrophils look okay.
That's exactly it. If you see bacteria, maybe lots of different types, just floating around without a significant increase in neutrophils, or without those degenerate changes, or without seeing them inside cells, it makes you much more suspicious of contamination from the upper airway during collection.
Right.
But if you see lots of neutrophils, they look degenerate, and you see consistent-looking bacteria inside them, that strongly suggests a true infection in the lower airways.
Got it. So the context of the cells is vital.
Absolutely vital. And this is why you always do a bacterial culture and sensitivity test alongside the cytology.
To confirm the bug and find the right drug.
Exactly. Cytology gives you the immediate picture of inflammation and infection. Culture tells you who the culprit is and what kills it.
Okay, beyond neutrophils and bacteria, what other abnormal findings might pop up? You mentioned mucus.
Right. Increased mucus is common. It just tells you there's irritation or inflammation stimulating those goblet cells to produce more. You see that with asthma, chronic bronchitis.
Makes sense. What about those other cell types, eosinophils and mast cells?
If you see an increase in eosinophils or mast cells, that points more towards an allergic type inflammation.
Like equine asthma.
Yes, that's a classic feature of many cases of equine asthma or IAD. Sometimes, though less common, it can indicate parasites migrating through the lungs.
Okay. And the bleeders?
The hemosiderin-laden macrophages. If you see those, it's confirmation of past hemorrhage, EIPH.
Anything else? Fungi, tumors.
You can sometimes see fungal elements like yeasts or hyphae indicating a fungal infection. And very, very rarely you might find neoplastic cells, tumor cells. But a tracheal wash isn't really the primary tool for diagnosing lung cancer. Other methods are usually needed for that.
Okay, this is incredibly detailed. So the sample's collected, the lab does its magic. What about handling the sample? Does that matter? And how does this all fit into the bigger diagnostic picture for the horse?
Oh, sample handling is critical. You've gone to the trouble of getting the sample. You don't want to mess it up afterwards. For the cell analysis, the cytology, the fluid needs to go into an EDTA tube. That's usually the one with the purple top. The EDTA stops it from clotting, which would trap the cells.
Okay, purple top for cells.
And for the bacterial culture, you need a plain sterile tube, or sometimes a special transport medium, to keep the bacteria alive but not let contaminants grow. No EDTA for culture.
Got it. Different tubes for different tests.
Yep. And making the microscope slides for cytology, that needs to be done quickly. Spread the fluid thinly, let it air dry fast. If it dries slowly or sits in the tube too long, the cells can change shape or even rupture, making interpretation difficult or, misleading.
So speed and the right tubes are key. Now, how does this one test fit with everything else the vet does?
That's a really important point. A tracheal wash, or its cytology and culture results, is never interpreted in a vacuum. It's just one piece of the puzzle.
Okay.
It has to be combined with the horse's history, the clinical signs, what the vet hears when listening to the lungs with a stethoscope. That's thoracic auscultation. What they see during the endoscopy, if one was done. And often, imaging comes into play too: chest x-rays, thoracic ultrasound.
So it's building a case using multiple lines of evidence.
Exactly. And it's also worth remembering the difference between a tracheal wash and that other procedure, the BAL, bronchoalveolar lavage.
Right, you mentioned that samples deeper.
Yes, a BAL samples the tiny air sacs, the alveoli, much deeper in the lungs. It's generally considered more sensitive for diffuse diseases like severe equine asthma, what used to be called RAO or HEAVES. A TW is maybe better for things higher up or more localized, like bacterial bronchitis or pneumonia. They give complementary information sometimes.
And quickly, just to touch on safety again, what are the main risks owners should be aware of with these procedures?
They're generally very safe procedures when done correctly. With the transtracheal, the TTW, the main things are that small risk of local infection at the site, maybe some minor bleeding or bruising, or that subcutaneous emphysema.
The air under the skin.
Right. Extremely rarely, the catheter could potentially break. But like I said, it's usually just coughed up by the horse within a day or so. It sounds scary, but it seldom causes a lasting problem.
Okay. And the endoscopic one, the ETW.
Less risk overall. The main thing is probably a minor nosebleed from passing the scope, eumetation. And perhaps the biggest consideration, though not a direct complication to the horse, is the need for meticulous cleaning and disinfection of the endoscope between horses.
To prevent spreading anything.
Absolutely critical. You don't want to carry infection from one horse to the next via the scope. Proper biosecurity is paramount.
Good point.
Yeah.
And ultimately, the outcome for the horse depends entirely on what the wash helps diagnose, right?
Exactly. The prognosis, the treatment plan, it all flows from getting that accurate diagnosis, which is what the tracheal wash is designed to help us achieve.
Wow. We've certainly done a deep dive into this. It's amazing how much information could be packed into that fluid sample, from the hands-on technique of the TTW to peering inside with an endoscope and then deciphering those cellular clues.
It really is. It shows you that interplay between the procedure itself, careful observation in the lab, and then interpreting what it all means.
Yeah.
And it highlights how those small details, like whether bacteria are inside or outside a neutrophil, can make a huge difference in figuring out the right diagnosis and, ultimately, the right treatment.
It really does underscore that difference between just finding something, like bacteria, and understanding if it's truly the cause of the problem contamination versus infection. Quite nuanced.
Very much so.
So, for you listening, maybe think about this. Where else, perhaps outside of medicine entirely, do we see similar situations where tiny details, things easily overlooked, actually hold the key to understanding a much bigger picture? It makes you wonder what other hidden depths of information are out there, just waiting for a closer look.
A great thought to end on. There's always more beneath the surface.
Indeed. Thanks for joining us on this deep dive.